Welcome to Hessel Schoolhouse. This is our second presentation on Blastomycosis. Before I get started, I've been asked to read a couple notes here, and I am going to read them because I did not write them. It's information about the Pickford Veterinary Animal Fund that is putting together this presentation. Blasto can be an expensive diagnosis and treatment, as anybody who has gone through this knows. The Pickford Veterinary Animal Fund helps people who cannot afford to diagnose and treat their own animals. Envelopes are in the office if you would like to donate either to the Animal Fund or to Hessel Schoolhouse. So that's my announcement that I was asked to make. So thank you for your attention. This is, as I said, this is the second presentation we've made. That's why we call it 2.0. And although we're going to focus on dogs, it also affects cats, other animals to include horses, and of course humans. Dogs are the focus of this presentation, as well as humans. We'll start off with the human connection first, and then go on to the dog connection. Okay, Damon, if I screw this up, we're right. Well, so far, so good. Again, we're looking at humans, dogs, and we're going to be in. Dr. Kauffman's going to be talking about treatment in humans, and Dr. Langlois will be talking about treatment and outcome in canines. What we learned after the first seminar, and since that time, with Dr. Kauffman's practice, with the Michigan State Veterinary, and also in Pickford, one of our purposes was to heighten awareness. Unless you're in an area where Blasto is endemic, you really don't know much or care much about it. However, if your dog gets sick, if your dog is here, he's asymptomatic while he's here, you go home a few hundred miles away, that you don't have an endemic situation, and he starts to act, as Doc Groover says, ain't doing right. And your vet doesn't recognize these issues or doesn't diagnose it properly early on, then you can have an issue. So at least at the Pickford Clinic, Doc has seen that there's been, and also down at Michigan State, they have seen an increased awareness on the part of animal owners and also of veterinarians. They've also increased the testing. I think Dr. Langlois will talk more about Mira Vista down in Indiana, and they have a highly specific test for blastomycosis. They can do a very quick turnaround on it and get you the information you need fast, which is critical when we're treating Blasto. The testing has increased not only with people while they're here, just a couple weeks before, even though their dogs are not showing symptoms, they'll have the dog tested prior to leaving just to make sure they haven't picked up anything while here. But then they'll go home, and if they've been paying attention to the veterinarians, a month or so later, they'll have another test done by Mira Vista, and this is simply a urine test they send in, or the veterinarian sends in, and they get a check at that point. So that didn't used to happen. In days gone by, they'd pack up the station wagon or the RV and head home and not worry about it till the next season. In the interim, they may or may not have an issue with their animal. So, and also with human infections. And I'm not going to get into Carol's territory here, but if you're compromised in any way and you've been associated with Blasto situation, you might be more inclined to pick that up. But I'll just leave it at that. There's been a lot of dogs saved since the last seminar, and we credit a lot of that to Dr. Kauffman, Langlois, and Groover making that presentation before. Today, we'll have these presenters, Dr. Kauffman from U of M, Dr. Langlois from Michigan State, Dr. Miller, cannot be here today. She did, however, put together a video presentation, and after Dr. Langlois talks, we'll have a short break, and when we come back, we'll look at Dr. Miller's presentation. I'll follow up with a little bit of information on genetics with this organism, the Blasto, to help more the veterinarians deal with the issues as opposed to the animal owners. And then at that point, Dr. Groover will talk to the group and make sense of everything that we've talked about before. Now for the mushroom. There are literally thousands of fungi all over the world. Most of them are benign. They make their living in a very secluded area. They don't bother anything. They don't stand out. They're around. Some of them are tasty to humans, such as this morel, and those we cherish. Other ones have a little bit of an attitude, and they tend to infect other organisms from which they can survive. In Blastomycosis, I'm going to be calling this either Blasto. Most of them I'm going to be calling it Blasto because if we go the genus and the species name, every time we talk about it, we're going to be here till 6. But the one most commonly involved with disease are Blastomycosis, dermatitis, and Gilchristei. They grow in the soil, and a fungus lives to reproduce itself. That's its sole purpose. We find them in case of Blastomycosis, we find them in water areas. When I get done with this clicker, I will have learned it, but until now and then, please. Wet areas and in woodland areas where we have decaying timbers. In general, wet shaded areas, if it's dry or alkaline, you're probably not going to find the Blasto. Couple more things about Blasto here. It grows in filaments, and these filaments, in technical terms, are called hyphae. The size of them is 100th the width of a human hair. And this is a 10-micron bar down here, and this 1 micron, so a little less than a micron. And the way they grow in their habitat is one cell grows, it gets so big, depending on the species, and then there's a wall that starts, and then another cell starts to grow at the end of that. That happens right here. And when, say they're on a log, they express enzymes that would decay cellulose or lignin to break down that tree. And they take that nutrient, use it for energy, and that's their life. They're happy. They grow like that for many, many, many years. Now, things will set them off to start to go into a survival mode. So they'll make structures that are called spores or conidia. In this case, this is a type of penicillium, and they're growing these spores, and once they get to a certain stage, they're now individually able to start another colony. When they're mature, a little puff of wind can blow these away. Something kicks it, it also blows it away, and each one of them potentially has the ability to start another colony. You see there's a lot of spores here. Now, what's Blasto look like? Not so much on the spore stage, the conidia stage. These are the Blasto forms of the little spores right here. So when one of these spores gets loose, it doesn't have as much of an army behind it of sister spores as do the aspergillus or the penicillin. But it's got a trick. This is at environmental temperatures. A dog walks by, he's rooting in the duff, and he gets a snootful of these spores, or in the eye, or in a lesion. Then he's at a higher temperature. The conidium. At that point, they shift to a yeast stage. In the yeast stage is where they infect humans and dogs. And at this point, I'm going to turn this over to Dr. Kauffman, who will talk about what we're dealing with in the human connection.
Okay.
Okay, now that's the pointer.
Yes. We'll see how well this goes.
I'll get away so I don't get feedback here.
Okay. Well, glad to be back up north and talk about one of my favorite fungi, Blastomycosis. The other one is histoplasmosis. Maybe some of you have heard of that one. That's more common down south, actually, but it does occur up here as well. So what is Blasto? Well, you've heard quite nicely from Bob what's Blasto. It's a fungus, and when you think of fungus, you think of bracket fungi and toadstools and puffballs, morels, but in fact, it's none of those. It's microscopic. It's in the soil, as you've heard, and on decaying vegetation. So it's not something you see out in the environment. You don't know if you're being exposed or not. You breathe in the fungus. That's the way it gets in, those little conidia or spores that you saw. And it's not spread from person to person, and it's not spread from animal to person, or person to animal for that matter, okay? So it's really inhaling it from the environment. So just one comment that fungi are complicated. You know that if you look at a morel or a great big puffball, and that complication means it has more similar structures to what human cells have, so it's much harder to treat. When we talk about treatment, you'll hear that we treat for months to years, so it's unlike any viral infection or any bacterial infection that you've probably been associated with, caused infection in you. So Blastomyces dermatitidis is the main cause. It was first described in the skin, that's why it's named derma, and it was first described by Dr. Gilchrist, who was a dermatologist in Chicago. And so the other species is Gilchristii, and the lab, when it grows them, can't tell them apart, and the clinical disease, we can't tell apart. So from now on, I'm mostly going to just say blasto, and mostly I'm talking about dermatitidis, with one big exception, which is Escanaba, and we'll talk about that in a little while. So you've already seen this. It grows as a mold at 25 degrees or at room temperature. This white fuzzy kind of turns tan over time. And this is what it looks like. Oh, how did that happen? I know how it happened. Can you go backwards? I keep going forward with both buttons. Okay. I will make no more mistakes. We'll see. So, and these are the conidia or spores. We'll call them spores. It's a little simpler to talk about. We inhale them. And in that phase, the mold in the environment, that's how we get disease. And then, as you've seen already, this lovely picture, when it's in humans, it transitions, complicated process, transforms basically over to a yeast. And this is what we see when we biopsy various tissues in people. And this is what continues to propagate inside us and dogs, for that matter. So this is where Blasto lives. It's interesting, the early maps sort of had this cutoff between Canada and the US, as if the fungi care, you know? And so really, it's a disease of southern Ontario, Manitoba, Saskatchewan, as well as the lake region up the St. Lawrence, and then down the Mississippi over into a little few tentacles over to the southeast. So this is where Blasto mostly occurs. So we've already known it occurs in soil, decaying wood, often along waterways, and again, Bob showed that nicely. Mostly we see individual cases. One person comes in, for example. Sometimes we see a person and their dog come in, and that's a hint to us as clinicians. If the dog has been infected and had some pneumonia, then we should always think blastomycosis, especially from this area up around here. There's some odd encounters. I don't know if I told you the story last time I was here. There's stories related to beaver dams, okay, and obviously the wood taken by the beavers and put there in their dams. And so there have been some outbreaks among Boy Scouts in Wisconsin. But the most, I think, amazing one is the Michigan one, in which the guy is bear hunting with his dog. The bear goes into a beaver dam. The dog follows in the beaver dam after the bear, and the hunter follows the dog. So the bear gets out, he's fine, but the dog dies, and the hunter almost died. He was seen in Petoskey at what used to be the Burns Clinic, and now is McLaren, and survived, but he was really very ill, and then lived to tell this story to the infectious disease doctors there. So, small outbreaks, mostly again related to outdoor activity, canoeing, camping, that sort of thing, clearing the brush from land. The largest outbreak, and I suspect you've all heard of this, in Escanaba. Anybody here who was in that outbreak? Nobody traveled from Escanaba, okay. Okay, so this was 2022, 2023. Overall, it's related to the Billerud paper mill in Escanaba, which is the biggest industry in Escanaba, evidently. 131 persons were identified by the Centers for Disease Control as having proven or probable blastomycosis. Now, other patients, other people were ill. They weren't necessarily identified as such, and so there's always a question of finding cases and figuring out who has it, who doesn't have it. The CDC had 131 very well proven cases and then decided to study those further. But clearly there were other people involved in this outbreak, so it's a huge outbreak. Largest outbreak of Blasto ever, and it's related to this specific paper mill. So here is the cluster. As epidemiologists will put things out on a map with time down at the bottom, number of cases here. And so this was first identified February 28th. The health department was notified there were 3 people who had blastomycosis, which is an unusual disease. Generally, Escanaba area would see maybe 1, perhaps 2 a year, okay? All of a sudden there's 3. And then this tells you here, these are the hospitalized. So these patients were ill, some of them, not the vast majority. The CDC, the health department actually sent an alert out to clinicians on the 6th. CDC was notified on the 3rd, okay? So the county health department was involved, the state health department was involved, then the CDC, and ultimately NIOSH. And NIOSH is the department that actually ran the investigation. So, and the investigation lasted from March through August of 2023. Remember, the first person presented in February of 2023. Can I go back safely? Okay, there, thank you for doing that. But in fact, when they went back and sent histories out, surveys out for people to fill in the blanks in terms of when they felt ill and whether they thought they had Blasto or it had been proven by their doctors, you can see that cases were occurring before that. Okay, and then continued on until July 7th, and the CDC said the epidemic is over. Okay, so they did a medical survey to about, I think they sent the survey to about 1,000 people who had either worked in the factory or were contractors who would come in and out of the factory, anybody associated with the factory, including secretaries and clerks, as well as those who were actually dealing with the wood. And they urged physicians at that point, CDC talked to several experts and said, what do we do about this antigen test? We'll talk about that in a minute. And so they urged physicians to start testing for this, which you've already heard a little bit about. And then in April, so I think it's important to know when, NIOSH came in, and this is an investigative body, and they sampled air ducts, filters, various places within the plant itself, as well as the outside. And then in August, they waited until August to sample this construction site that was outside where they're building a bridge of some sort near the paper mill. So what's the result of all that? This is the mill, and I think you can see here, this is where most cases occurred in this paper machine line number 1, but here's number 3 and number 4, maintenance, pulping, the wood yard, the administrative offices, everybody was getting Blasto. Actually, it wasn't just those who were working on the line who were having the big logs go through and then mashed up, however they do that, to make pulp, okay? So this, to me, means this is pretty complicated. If this was this extensive, and again, it was investigated in terms of the actual samples in April, which is probably several months past the time when people were exposed to the Blasto from the wood or from the soil. In the end, they had 533 environmental samples, and they tore the HVAC system apart, tried to sample from various places, as well as other places in the plant and the environment. Nothing yielded Blastomyces. So they couldn't find the organism. They couldn't find where it came from. They did grow the organism from 8 patients who were ill. These were more of the hospitalized, the sicker patients, and from a dog who was sick in nearby area to the mill. And they all grew Blastomyces gilchristii. So not dermatitis, but gilchristii, which actually in retrospect, when you look at various outbreaks in Wisconsin, gilchristii is many times the main pathogen. So this subtle difference between these two, which maybe Bob's going to tell us about later on, perhaps means that gilchristii is a little more likely to cause an outbreak. It's not totally clear. And so the mill was shut down in, I think, mid-April. Opened up later, early part of May, so 3 weeks it was shut down, cleaned up, no cases subsequent to that. So bottom line, nobody knows where the Blasto came from. Presumably from the logs that were brought in or from the soil that was disrupted as they were constructing this bridge. It was clear that most of the filters going into the plant were not, or most of the not filters, but the entrance of air into the plant was not filtered. And those that had filters weren't very well cleaned, okay? I'm sure it's hard to keep things like that clean in this dirty pulp mill situation. So don't know what it was, where it came from, and it's gone away and it's not come back. And unless somebody knows anything different, that's all I've been able to glean from the CDC or NIOSH. To me, part of the problem is NIOSH took over, and they were mostly dealing with the instrumentation within the plant and how it got into the plant. Whether the CDC would have done a little more extensive investigation a different way, it's kind of my bias, but they weren't the ones who were primarily responsible. Okay, so let's talk about the fungus-host interaction, okay? So healthy people get Blasto. Most of these workers were young, healthy young men who were ill with the outbreak. But immunosuppressed people, those who have something the matter with their immune system, also get Blasto, and they probably get worse Blasto, okay? So The bottom line in terms of disease depends on how much Blasto you take in, and you can get a huge dose, or just a few little spores. And it also depends on how your immune system reacts to that and how well it can fight it off. So it's a balance, okay? Oh, importantly, symptoms begin weeks after exposure, sometimes months. So again, with this outbreak, probably exposure was maybe months before, and then the patients start getting ill. So the disease itself, since the spores are inhaled, then it's mostly a pneumonia or a respiratory disease. And sometimes, actually most times, it's just a little cough, maybe a little touch of fever. Patient gets better in a few days, okay? And never knew they had something called blastomycosis. On the other hand, there are patients who have a more chronic form of disease, and I'll show you one of those examples, and have fever, weight loss, fatigue, and this may go on for several months before the diagnosis is made. And then the third thing is that if you get a huge amount of spores, you can get acutely ill, like the guy who went in after the dog, who went in after the bear, and have a terrible pneumonia and die within days of presenting to the hospital. So it depends how much you get and what your immune system is like. A couple examples. This was a young man who was at soccer camp in Wisconsin, U of M student, and came in and had a cough, fever, felt terrible, and as you can see, has a patch of pneumonia, okay, which was later found to be Blasto. Here's another example, and this patient was sick for weeks and came into our hospital. He worked putting in furnaces, and so he worked in some cellars sometimes, Michigan cellars, in the dirt, and he had this infiltrate here, this round spot here, and we were sure he had cancer. We're starting laying the crepe, well, we're sorry you have cancer. Took a biopsy, it was Blasto. And then we were excited and said, oh, we're glad you have Blasto, because we can treat this. And he did fine. Two more cases. So this is a healthy woman from the Traverse City area. I got the slides from the docs up there. Came in with a pneumonia over a couple of weeks. Here you can see it. And didn't respond to antibiotics, and this is a pretty common story. Antibiotics are used first. And then, 1 week later, after these 2 courses of levo, this is what happened to her entire left lung, is full of pneumonia or infection, was having high fevers, couldn't breathe very well, had to be put on a ventilator. And then the story came out, I should say, when the infectious disease doctor came by. Anyway, she spent a lot of time cleaning out a boathouse on the southern shore of the UP, over to the west of the bridge. And her dog, the husband, her kids, none of whom helped her, none of them were sick. And this was kind of the clue right there. Then the diagnosis was made. She responded to the therapy that we'll talk about in a minute and did just fine. And one more case, this is a young boy. Obviously, I did not see this child. I'm not a pediatrician. But he lives in Palo Alto. And so the slide was sent to me by the docs out there who were not sure what was going on. He got sicker and sicker and ultimately needed a surgical procedure to drain the fluid from the outside of the lung on the right side. All of their tests, and they do many at Stanford, believe me, all of their tests were negative except for a Blastomyces test. And that's when they called and said, how can this be? And it was because he had visited relatives on Drummond Island. And as you all know, this is a hotbed for Blasto up here. And it was in the month before. His twin did not get sick. So somehow they must have done different things out in the environment. So important message is that it can occur, Blasto can occur weeks later to months later when you're someplace else. And Bob alluded to this, and then the diagnosis is difficult to make because nobody ever heard of blastomycosis out there in California, okay? So the other point is it often doesn't stay in the lungs, but will travel through the blood, especially to skin, and I'll show you a variety of skin lesions. I think you'll see some from the veterinarians as well that occur in dogs. It also goes to to bones and joints, prostate in men, and it can go to the brain. Usually that's in somebody who's immunocompromised and has not a normal immune system. So these lesions, okay, again, through the blood, you don't get it by inoculation, usually are not painful, not itchy. They're just there and they don't go away. So that's one clue. But sometimes they ulcerate. Sometimes the patient has pneumonia at the same time, which makes it easier. Other times it's just a dermatologist who sees these patients. So a few examples. This patient was in our nursing home at the VA, and you can see there's shades of mercurochrome around this lesion when we used to have mercurochrome. That's a long time ago, isn't it? And so the nurses thought they could treat it, but of course then when it was biopsied, it was Blasto. Here's another in a dark-skinned person, and this is Blasto. I have no idea what this patient was thinking or not thinking of, because this enormous lesion on his thigh had clearly been there for several months. Obviously not painful, didn't bother him a whole heck of a lot, but on biopsy, again, was Blasto. This lady quickly went into Petoskey because it was involving her eye. And again, this is a sort of a dry, heaped up lesion, Blasto. And then one, I think I have two left. Here's one with a patient who had these multiple lesions erupt. And they are Blasto, as is this ulcer. So it can do a lot of different things. Biopsy is the most important thing you can do because you see that fungus and you make a diagnosis. So immunocompromised patients, I'm talking about people with HIV that's advanced. I'm talking about transplant recipients or patients who have some sort of gastrointestinal or skin or joint involvement and are on drugs like tumor necrosis factor inhibitors. They're advertised on TV all the time, and they're very expensive. They treat these diseases wonderfully well, but they put you at risk for dissemination of infection. And as you can see, the brain is often involved, the pneumonia is worse, and mortality is higher if you don't have an immune response to fight this with. So, diagnosis, think of it first off. And I think that's now happening with veterinarians here from the former seminar, according to what Bob says, and I would certainly think that's great. I think after Escanaba happened, the physicians there began to think of it quickly when the health department told them about it. Culture makes the diagnosis, but it may take weeks to grow. These things are slowly growing. So if you biopsy and see this picture, I reproduced it here again, that tells you right away it's Blasto, and you can proceed with treatment. There are antibody tests which tell you how well the person is responding to the infection, but they're not very good for Blasto. In fact, they're terrible. So they're probably not anything you want to get done. And I don't think it's anything the veterinarians use either, but we'll hear from them. And then this antigen test. And this just means it's like pieces of the fungus that are broken off as the host is responding to it. You can find them in the urine, you can find them in the blood. And so that can help you make a diagnosis very quickly. And it sounds like you have a conduit to Indianapolis here, so you quickly get the answers back from Mira Vista. So, a little bit about treatment. All patients should be treated with Blasto. I think that's a good axiom to take away. You should be treated because it could come back, could relapse years later even. I've seen that. And it also can continue to cause problems in various organs. So everybody should be treated. Everybody should be followed because the drugs that we'll talk about are not that easy to give. They're not that safe. And they have lots of side effects, but they're remarkably good. And again, you need to treat for a long time to be sure that everything is responding. So, two kinds of drugs. Amphotericin B is an intravenous drug, and then azoles, and we'll talk about certain of those, which can be IV or oral. So amphotericin B, if somebody is really ill, or somebody's immunosuppressed and likely to get very ill, we use amphotericin B. We use it IV. It's toxic to kidneys, so you have to know how to give it and how to modulate the use of it so you don't actually cause more problems, but it's life-saving. The bug responds very dramatically to amphotericin. Then step down when the patient starts getting better, or if the patient isn't very sick to begin with. And most of the patients in Escanaba were not that ill, and most of those patients were treated with an azole. The drug we use, and you're going to hear this from the veterinarians as well, I think, is itraconazole. Sporanox is the brand name, okay? It's a capsule or a liquid, and absorption is an issue. So again, you have to know how to use this drug to make sure that you are using it effectively. It's not a simple thing like a penicillin, for example. It also can damage the liver, not common actually, but the main issue with it is interacts with so many other medicines that almost everybody seems to be on, especially as you get older, on more medicines, and you have to be careful about these drug interactions. So we treat for 6 to 12 months. So again, the fungus grows slowly, and it takes a long time for those cycles to be happening so that the drug can actually work on it while it's actually growing. So it takes a long time to treat, and to prevent recurrence, we usually treat for about a year. And I'm going to stop there. Just remind you that even though I've been talking about a bad actor, there are wonderful fungi. And where would we be if we didn't have fungi? No chocolates, no beer, no wine, no cheeses, no breads. Life would be horrible, wouldn't it? Okay. So, and that's all I have to say. Thank you. Okay. I can take questions now.
I have one question. If you,
You gotta wait.
oh, I thought she asked a question.
She does, but we're recording you. And I know you're in the witness protection program, but
Thank you. In the event of a test that you do somewhere other than this area, what are the chances that a doctor who doesn't know about this will, or the radiologist or whoever, will read the test and have no idea what it is?
So, I mean, if a test is ordered like an antigen test, or certainly a culture, they will know what that is. If they're not sure how to treat it, they'll usually contact somebody who has treated it and get some advice, or go to some book, textbook. People still read textbooks, I think, or Google how to do it. I think the main thing with people who aren't familiar with Blasto is they wouldn't order the test. You see, they would get a chest X-ray or a CT scan and see something that's non-specific. It just says, oh, there's pneumonia. But then you have to know how to order something. And the lab has to know how to culture it. So for places that are far afield from where Blasto occurs, most of those labs probably don't know how to grow Blasto. And that can be difficult. It takes weeks to grow sometimes. Yeah. There was another comment.
down here.
Yeah, I was going to ask. So if it takes several weeks for the culture, as you say, do they still recommend doing that, or would the biopsy be
Yeah, so obviously you can make a diagnosis by a biopsy, especially if it's a skin lesion. Boom, you can have a diagnosis in several days. Or the antigen test. So you have to be a little careful with antigen tests. There are different labs that do them. There are commercial labs that do them as well. Mira Vista is commercial, but it's more of a reference place. I tend to trust their results more than ARUP or Quest or some of the other commercial labs, but a lot of hospitals contract with those commercial labs. So I'm not sure I would trust their antigen tests as well. The culture will tell you what species it is. Like in the case of this outbreak, it was enormously helpful because it's Gilchristei. And that's unusual, and I'm sure that was helpful to the CDC people anyway. You treat it the same, no matter which one it is. So I think it's a helpful adjunct to make sure. I'll tell you that the criteria set up are, if you have a positive antigen test, it's probable Blasto or probable histo, and the two of those in humans cross-react. The test will be positive for both Blasto and histo when the patient has histo, or when the patient has Blasto, they'll cross-react. So that it's helpful to have actual culture proof or biopsy proof.
And what was the lab you you like to use?
So
that
it's Mira,
question?
M-I-R-A, Vista.
Okay.
It's in Indianapolis, and they invented these tests. Now, subsequent commercial labs have taken them over, and there's another lab called IMI, Immunomycologics, and they have other tests as well for these fungi. So a positive test isn't always truly positive, a negative test isn't always truly negative, you have to know how to interpret them.
Are the veterinarians using these labs as well?
I think the veterinarians are probably using Mira Vista, but you'll hear that.
Oh, okay.
Yeah.
Thank you.
Okay.
I have a quick question.
Oh, another question, yeah.
Can you test the soil? When Bob was saying how quickly the fungus grows,
Yeah,
you
so,
suspect like your dog is digging or you're going to do a construction project, do you test the soil?
so the question is, you test the soil. It's really hard to grow Blasto from the soil. And it's even hard to find it with genetic tracing, like this PCR that maybe you've heard about. And look at that, they did all that environmental testing at the lab, at the paper mill, and couldn't grow it. That's not unusual. So Blasto is not simple to grow. And many times, again, we don't know what area of soil it was or what area of the mill it was when people got ill. Oops, one more.
For those of us that have bird dogs that run our dogs a lot and live in a cedar swamp, would it be effective? Would it be proactive for us to be testing every 6 months or something before they become asymptomatic?
I'm
Or
going to have the veterinarians talk about that. We don't do that in people. And I think that's because it's a rare disease in people, actually. So within a certain area with a certain species, like dogs, then maybe it's effective, but I don't know that. I'll let the vets talk about it. 2 questions, okay.
If you have had Blasto and it was mild and you didn't even know you had it
Right.
and recovered, do you need to, I mean, I don't know what you need to do because you say it can recur.
So yeah, if you've had Blasto, let's say you were part of this sort of outbreak, and there were people who were tested, found to have had Blasto, never had any symptoms. I don't think they treated them. And the advice from the CDC was you don't have to treat if you're asymptomatic. If you have even mild symptoms, you should be treated. And clearly, if you have severe symptoms, you'd be treated. And if you've had Blasto, then presumably you should be immune for future exposure to Blasto, unless something happens to your immune system.
Would that be true for histoplasmosis as well?
Yes, it's also true of Histo. We have more experience with Histo than Blasto. It's a much more common fungus infection in the Midwest, actually. So we know a lot about Histo. We're sort of learning about Blasto. Yeah. Another question?
Who has a question? Another comment.
Hopefully Dr. Kauffman will agree with me. Usually the decision isn't biopsy or culture. Usually if you bother to do a biopsy,
Yes.
whether it's lung or skin, you're saying, hey, this ball in the lung could be tumor, maybe infection, but I'm more worried about tumor. Oh, well, I'll culture it. Also, you tell the medical students, don't you dare get a piece of tissue and not do everything possible
Right.
with it. Same with skin. Is it tumor? Is it infection? Is it something else? Ideally, they should be doing both.
Yes, absolutely. Yes, and I think most dermatologists and pulmonologists do that, absolutely. Oh, another question.
Okay, we'll take one more here, and then we'll continue the. I can wait. No, I walked all the way over here.
Hey, thank you for being here today, first and foremost. We're on our second dog with Blasto, so we've got a little experience in this with the animals. But my question is about the environment with which they get it. And I know the young lady over there mentioned a cedar swamp, but I feel pretty confident behind our cottage is a low boggy area, and he spent some time back there, our last dog, and I think that's where he picked it up. But we have 2 dogs, and the other dog has never gotten it, while the other 2 dogs had. So my question is shoreline. When the water fluctuates like it is now, so it's really low, and it exposes, I'll call it the muck or it's like mud almost in some areas if it's not sandy bottom. Is that an issue, or can that be an area, or because that is, if it's exposed to the sun, I saw something about in the shade, and what are the, what's the thought on that? And shout out to Dr. Groover. He saved our first dog from 500 miles away, so.
Well, that's good. Bob, do you want to answer that?
The fluctuation of the water level there, you say with the muck up and down. The Blasto, that's too extreme for Blasto. Okay. I would look maybe upland, a couple, say a foot or two upland as you go. They like the moisture, but too much moisture, you're not going to find them there.
So sunny shoreline would be even a better scenario because it's drier, right?
Worst scenario along the shore. Yeah. I mean, again, decaying wood, vegetation, that kind of soil, I think is what Bob's saying mostly. Yeah.
Yeah. So thank you very much. I'm going to have to take your mic here to get it over to Devon, is that going to work? A comment about the incident in Escanaba. The same time this outbreak occurred, they were rebuilding the bridge about half a mile downstream from there. And that was about a year-long, 2-year project. And in the report that Dr. Kauffman's talking about, they found no Blasto cases from all the workers down there. So, still questions. You on, Daniel?
I think so. Can you guys hear me okay?
Okay.
All right, well, perfect. So I'm glad to be back again. So I was here 3 years ago. Am I too loud? No, okay. Okay, perfect. So when I came 3 years ago, I just wanted to show this picture. We were in this room, we gave our talks, and I just was commenting on how beautiful it was up here. And we met a guy in the audience named Neil Young, can't forget the name. And either way, he said, well, why don't you guys come fishing with us? And so literally right after the conference 3 years ago, he took us out on his boat. And that's my wife. She caught a few pike, I caught a few bass. And so either way, I just figured it appropriate to show our last memories. And so it's beautiful up here. We loved it. Glad to be back. And so Carol talked about a lot of the same things I'll probably talk about as well. And one of the things that we're always trying to think about as clinicians, and so I do internal medicine at Michigan State, is when we're considering whether or not we think a dog might have Blasto or one of these invasive fungal infections, what are the risk factors? And this was a case we saw a few years ago, and I guess the bear hunting theme, maybe it's a common theme, I don't know, but this was a dog that we saw in November, and there does seem to be a seasonality to Blasto for us, but part of that seasonality is likely that is when everybody's leaving the Upper Peninsula, coming back downstate. The disease has incubated for several weeks, a couple of months. And so we see most of our cases in late summer and fall. Doesn't mean that's the only time we see it year round, but that's when we see most. But this was a case in which there was multi-systemic illness. The dog had respiratory signs, labored breathing, losing weight. It was lame. We see bone involvement. I'll show pictures later. It's a hunting dog. It had been to the UP. This is, everything screams of this dog probably has Blasto, and it kind of goes into, well, what are the risk factors? And we often talk about risk factors for the disease based on the animal. So what's unique to the animal that puts that animal at more risk? And we do know, as has been mentioned, dogs seem to be sort of a sentinel species. We see it more in dogs than we do in humans. Cats, we do see it. We diagnose a cat or two a year, but not very common. Males more common, intact dogs are more common, hunting dogs, sporting breeds, retrievers. But realistically, all of these intrinsic factors probably don't mean that just because the dog is a male that he's at greater risk. It's just these are the dogs that are exposed to it in the environment. These are the dogs that are hunting dogs that are roaming the area, that have their nose in the ground. And probably one of the biggest things for us is the animal in an endemic region. And so that's probably the biggest thing is, were you in the Upper Peninsula, Emmett County, Sheboygan counties, in the northern Lower Peninsula, are all these really, really big hotbeds. This was a story that I read last year that was published in the Detroit Free Press, and I was very sad reading it because it was highlighting this, was a Blasto case in a person, and he had initially went in for what was presumed to be prostatitis, treated with antibiotics, didn't really get better, developed a mass in his throat. They lanced it, drained it, thought it was an abscess, same thing. This is common in dogs and humans. They get thrown on antibiotics because all of this is assumed to be bacterial infections. He ended up being airlifted to U of M, died, horrible respiratory complications. But what I was reading is that his dog had died of Blasto a year and a half prior. And it just kind of, I think, highlights this One Health concept. We're all in the same environment, we're exposed to the same things. He didn't catch the disease from his dog, he caught it from the environment, but they were in the same environment. And I was reading, I was like, gosh, are they not thinking Blasto? Are they not thinking Blasto? But as Dr. Kauffman mentioned, you have to have awareness. And so obviously he was, he's from Boyne, he was probably, they in the story said he was a big hunter, hiker out in the woods with his dog all the time. And so again, I do think that there was probably a clue. The dog dying of Blasto a year before would have been a big clue. Dr. Kauffman showed a couple of maps, and I show these because this is sort of our gold standard textbook in internal medicine. And you see Blasto are the pink and dark pink lines, and you see what is left off of the map. The entire Upper Peninsula is left off of the map. And this is a human medicine publication, and kind of the same things. I guess maybe it's a better map, but Blasto is this blue to kind of pink area. And at least they have most of Michigan, but again, the Upper Peninsula is left off. And so I think there's a lot of practitioners outside of the UP that aren't always aware of Blasto being so hyper-endemic in the UP. And this is, I showed this a few years ago. Dr. Groover was nice enough to share this letter that he wrote to, I think, the director of the diagnostic lab, or was it the dean of the college in the early 90s, basically saying, we're seeing all of these dogs with Blasto, and you guys aren't recognizing it. Like it's there, you guys need to be aware, you need to teach your residents. And so, back then, and Dr. Bill Shaw was one of my mentors, and so they were some of, I think, the first, people to really try to raise awareness of this disease and make, not just other veterinarians, but lay people aware of it as well, because it is such a potentially deadly disease. And so a few years back, we actually did a study where it's kind of a two-part study, and I'll go through a little bit of it. But we contacted basically every veterinary clinic in the Upper Peninsula. That was an easier task. In the Lower Peninsula, there's way more vet clinics, so we didn't contact them all, but we tried to contact anywhere between 2 and 4 veterinary clinics per county to basically survey them. How often are you diagnosing blastomycosis? And you can see that pretty much the Lower Peninsula, very little except for Emmett and Sheboygan counties. And then pretty much everywhere in the Upper Peninsula, except the Keweenaw Peninsula, that seems to be real. Doesn't seem to be a hot spot from anybody that I've talked to. These areas, I think they just weren't testing, but you can see, Pickford, Drummond Island, these are all really, really big hot spots. And so we also, we asked all of these owners different, questions about where they had been, where they had traveled. And, the big thing for us that we found is if they had traveled north of the 45th parallel, that dog was basically at 13 times the odds of developing blastomycosis as compared to a dog that had never been above that 45th parallel. Again, not surprising to us who know that this is where we see the disease, but I think, again, just highlighting awareness. And so this is part of that study. We had this spatial scanning software that looks for high-risk clusters and low-risk clusters. And you can see, again, the northern tip of the Lower Peninsula, a lot of the Upper Peninsula. The western part of the UP would have all been circled too. We just don't have enough cases from there. If they get really sick there, they go to U of W, not MSU, so we don't have a lot of the western UP cases. But again, it's very much an endemic and hyper-endemic disease in northern Michigan. And so we kind of sketched our own map as to where do we think the disease is. And again, most of the UP, the very northernmost part of the Midden, and then a lot of area here, similar to the Huron-Manistee Forest as well, we see cases from too. But the southern part of the state, again, not that there's never cases, we see sporadic cases from everywhere, but almost all of the cases that we see, either UP, Emmett, or Sheboygan counties, there's some connection to those. And as Dr. Kauffman mentioned, it's sometimes a few weeks, to even 4, 5, 6 months after they've traveled to these regions too. So there can certainly be a very, very long incubation period. Unlike humans, where asymptomatic disease and even spontaneous recovery appear to be common, we don't really see that in dogs. Now, it doesn't mean that it doesn't happen. It just may be that if a dog had this occur, we would never know, right? You're probably not bringing your dog to the veterinarian for chest x-rays if they were never sick. And so we don't know if that happens, but the dogs that we see are sick. And that, I think the ADR thing must be a veterinary thing. I guess they probably don't use that in human medicine, but we say, you know, the ain't doing right's a common, you know, thing that we often will refer to these dogs as, because it might not be a clear-cut, specific localizing sign, but they're off. They're lethargic, their food intake is down a little bit, but generally they are sick. And the big thing that we see are pulmonary or lung manifestations, by far the most common manifestation. And if you read the textbooks about Blasto, they often will describe the classic lesions, basically that, you know, somebody took one of the snow globes and shook a snow globe, and that's what the chest x-rays look like. And this is sort of the classic x-ray. And you can almost appreciate that all of these are little bitty tiny nodules throughout, and this dog just has nodules throughout its entire lung field. But that's about half of the cases, and we see a lot of other manifestations too that aren't always classic. This was a dog where they actually had property in the UP. They had a big excavation on their property. They were remodeling and adding a sort of a guest cottage to their property. And this is a dog that has, you can appreciate this just sort of fine white haziness in its lungs. And we call it an interstitial pattern. But as was referenced earlier, depending, you know, this could be a lipid pneumonia, it could be an interstitial lung disease, it could be pulmonary fibrosis. And so again, if it's not on your radar, this could easily be overlooked. This dog was treated for a very long time and did great. This was a dog, and this is, I think, probably one of the more common misdiagnoses we see. It actually came into our surgical oncology service at Michigan State. It has this big mass that you can see right there, and it's got a smaller mass right there. And so the presumption is that it had cancer. It had lung cancer that had likely metastasized or spread to the regional lymph nodes. So they went in there surgically, they cut the lung out, biopsied the lymph node, $8,000 worth of this. Not that it's, I mean, the dog was fine, but a very expensive way to become fine. And the bigger history, again, traveled to northern Michigan, the dog had been lethargic, ill. Again, there were a lot of things along the way that probably would have made, you know, the internal medicine group, where, you know, the surgeons think differently. They're, you know, they always say a chance to cut is a chance to cure. We, you know, the internal medicine folks approach it a bit differently, but again, a lot of clues. So this was a dog that came from a household of, there were 3 golden retrievers. They had a cottage on Burt Lake. Spent a lot of time just kind of free roaming. All 3 dogs were diagnosed with blastomycosis, which again, we sometimes will see clusters. We sometimes see it where one dog in a house will get it, none of the others do. But this is a dog where, again, initially they thought it was going to be cancer. There's a nodule there, nodule there, nodule there. And so the initial thought was this dog was going to have cancer. But no, again, the history, where the dog had been, this was another case of blasto. But again, the x-rays can look so different. The disease can manifest in so many different ways. This was a dog that was seen down in Florida, and you can see these, you know, the whiteout of the lungs, and even here, this big, thick, white area. And it was, you know, pneumonia. This is going to be a bacterial pneumonia, and it wasn't better. They called Doc Groover. They were like, you know, and he's like, no, it's going to be blasto. I got involved as well, and sure enough, it was blasto. And so blasto can absolutely look like a run-of-the-mill pneumonia, and in this case, it did. This dog ended up was treated well and did well for quite some time. But again, it can have many different faces. It's not always the classic snow globe-looking lung. You can see many different manifestations. So the dog that I showed you a second ago that they thought it had a lung tumor and it went to surgery, this is actually the same dog. It came in for coughing up blood about a month and a half into its treatment. And what you can almost see faintly is this big, giant bubble in its lungs. You can see this huge bubble. And so this is a pulmonary bulla. It's an accumulation of air that's basically effaced the lung tissue. And we actually see this in about 5% of our cases as well. And so this dog that already had a lung lobectomy that it probably didn't need, now needed another lung lobectomy when it actually did need one. So this was one of my most memorable cases just because the dog went through so much. And so again, many, many different manifestations of disease. And so from an x-ray standpoint, most dogs have lung lesions. Nothing is ever 100%, not all of them do. This was a dog, I'll back up. This dog didn't survive. You could imagine its lungs were basically riddled with disease. This was a young standard poodle that we saw. But the patterns aren't always classic. And so again, there's the textbook examples, but we see many, many cases that don't look like those. And so again, I think this is where awareness makes such a big difference in actually reaching a timely diagnosis. Just like in humans, the disease tends to disseminate in dogs, so it's usually that route of infection is through the lungs, but it often spreads to other body systems, and so we see lymph nodes involved, eyes, prostates in intact male dogs. Most of our dogs are neutered, so we don't see that as commonly, but for intact dogs, we absolutely can see that. Bone, skin, all of those. We occasionally see dogs with heart involvement, with central nervous system involvement, so again, it can spread almost anywhere. Many of these signs occur in conjunction with the respiratory abnormality. So oftentimes it's a coughing dog plus something else. There's eye issues, there's skin issues, there's lymph node issues, there's a lameness. And so that's another big clue for us as practitioners, because there's not a lot of bacterial or viral infections that will cause lung involvement plus some other involvement of some other system far away. And so many of these cases, we're often thinking it's either going to be fungal or it's going to be cancer. And obviously, if those are your two differentials, you're hoping it's going to be Blasto because it's way better than disseminated cancer. And so these are some of the skin lesions we see in dogs. So this is sort of a nodular draining lesion right behind a paw pad. There's also a crusted lesion. So same dog, but two different looking lesions on the same dog. And so many of the dogs, the studies say about 50%, if you look hard enough, you can often find skin lesions in many of these dogs. And again, many times they go on antibiotics and nothing's better. And again, that's another big clue that we see. This was a German Shepherd that had these draining sort of fistulas and tracts. There's one in the interdigital area. Same dog again, but another one of its lesions was this thick plaque-like lesion. So again, the skin lesions can take on a variety of manifestations. We see a lot of eye involvement in dogs, and it affects what we call the posterior segment or the back of the eye. So this fungus will set up shop on the retina, and so this is the optic nerve. This area back here should be a nice, smooth, refractile green retina or fundus. And what you can see are all of these massive hemorrhages. All of that red is blood. So this dog is hemorrhaging onto the back of its eye. All of these little white dots are fungal plaques. So they're basically mats of fungal organisms and inflammatory cells. And so we see many, many dogs that have visual deficits. And in some cases, they lose their eyes because of the severity of this infection. And this was a dog that came in for a right forelimb lameness, had multiple nodular skin lesions, and the visual deficit. So again, multi-systemic disease. And this was actually a French bulldog, so by no means the classic breed that we're diagnosing Blasto in, but it was a Frenchie that came up north. And so again, same thing, had the environmental risk factors. This was a hunting dog, and you don't have to be an orthopedic surgeon to recognize that there's this giant punched out lesion in the tibia, and this is another view of it. You can see this giant lesion, and normally the bone would just run straight down, but there's all of this proliferation of bony tissue. And so this was a dog that had been to his vet. They thought it was an abscess, drained it several times. Sure enough, it was run-of-the-mill blastomycosis. All of these dogs made recoveries, but I'm just showing you kind of the many different faces that Blasto can take in our veterinary patients. This dog did not make it, right? We have a picture of the brain on the PowerPoint slide, but this was a dog, you can guess by the name where the dog had been, right? This dog was named Petoskey, clearly had been to an endemic region, a number of neurologic signs, horrific spinal pain, was nearly forelimb paralyzed, still had a little bit of function, but very close to it, very dull mentation. They ended up doing an MRI on this dog and presumed it had a brain tumor. And on necropsy, it was actually determined to be a big mat of fungus. It was Blastomycosis as well. And so again, we can see a variety of manifestations with this disease. And I kind of, is Blasto the great imitator? And I think it is. It can present in so many different ways, so many different systems can be involved. And so from, I think, our standpoint, again, maintaining awareness is probably one of the best ways that we can catch this earlier. And so, probably a common question that many people here have is, when should we be thinking about it? And maybe I did it backwards, but has lung disease and a coughing dog. They're going bacterial pneumonia 99% of the time unless they have experience with this disease. And so I think just like in human healthcare, you've got to be your own advocate in many ways. And I think the same thing is true in the veterinary world as well. And being aware of this can be life-saving in some situations. I'm not going to spend too much time on testing. There's a ton of things that can be done. We're often making most of our diagnoses on cytology or biopsy samples, or on the antigen tests that Dr. Kauffman mentioned as well. And so this is, again, you've seen pictures of this already. It's this classic broad-based budding yeast. So this is the yeast reproducing or dividing right there. It's got this very classic appearance. The cytoplasm or the wall is very deeply basophilic. And we can usually find organisms in sick dogs. And so in humans are often taking a biopsy or getting a chunk of tissue. What we're often doing is taking a small needle, the same size needle that a dog would get vaccinated with, and we're sticking it into lymph nodes, into a diseased skin lesion, and just spraying that out onto a microscope slide. It's not even a full biopsy, it's just what we call an aspirate. And in most cases, we can get a diagnosis off of an aspirate. And so when we have animals that are suspected for disease, even if it's the coughing dog, we're looking for skin lesions, we're looking for lymph nodes that might be just a little bit big, and we're sticking needles into them. In most of the cases, we get an answer that way. So same day diagnosis in many of these cases. But there's certainly a number of cases where that doesn't always happen. And there's a lot of cases that I think are diagnostic challenges, and I think it all goes back again to awareness. But this was a cockapoo and these came into Michigan State. So this is in our own hospital where all of these are happening. And this dog had been sick for a couple of weeks and appetent for a week. And you can see this sort of, pneumonia type looking lesion, but you can see this little lucent center. And so because of that lucent center, they thought it was gas, so they presumed that this was a pulmonary abscess. So they took the dog to surgery. Again, the dog did okay, but getting a CT scan and a lung lobectomy, $6,000, $7,000, $8,000 at Michigan State to do this. And the dog resides in Traverse City, which isn't a hotspot. Traverse City is not a hotspot for disease by any means. But what was never asked until we went back and looked at the case when we were contacting owners, they had traveled to the Upper Peninsula 3 months prior, but it was nowhere in the initial medical history. And so again, the dog ended up being fine, but probably a miss. And just to show you, again, the dog was fine, it ended up being okay, but didn't really consider a detailed travel history. And just to show you sort of the converse or the flip of that, this is almost the same exact case in terms of the presentation. Very similar sort of pneumonia-like looking lesion, very consolidated lung lobe. This was a dog where a good history was taken. The dog resides near the Sioux. It had been lethargic. There were other things going on with the dog. And so we aspirated it. So this dog, same kind of presentation, same kind of case, diagnosis made for $200 versus $6,000. And obviously the same outcome. Both dogs were successfully treated. And so again, I think we can often, if you're thinking about the disease, you can usually find the organisms. The other thing that we rely on a lot too are those antigen tests. So just like Dr. Kauffman mentioned, we do not do very many antibody tests. We mainly are doing antigen tests. And this is, again, through Mira Vista Laboratories, and we use them because they have published the most. We've done studies with them. They seem to have a very accurate test. And sensitivity refers to how likely is the test to detect disease in an animal that actually has disease. And so in urine specimens, about 95% of dogs with Blasto will have a positive test. So again, it's not perfect. It doesn't capture every single case. But for the most part, it's a great non-invasive way to make a diagnosis. She mentioned that it does cross-react with histo. Histo is a much bigger problem in humans. we rarely see histoplasmosis in non-immunocompromised dogs in the state of Michigan. Now, the dogs that we see that have histo have been to Indiana, Tennessee, Ohio, and so unlike in humans, if we have a positive antigen test and the dog has only been in Michigan, it's pretty much blastomycosis until proven otherwise. And so we use a lot of the antigen test as well. And this is just an example of another case and kind of how we use the test. But again, a sick dog, Upper Peninsula history. The dog had ocular lesions, its retinas were detached, it was blind. On x-rays, it had this lesion here. The owners were very reluctant to stick a needle into it because there was still some aerated lung around it, so you always worry if there's a lot of aerated lung and you stick a needle into it, could you lead to leakage? And so they ended up wanting to withhold aspirating, and so we submitted the urine antigen test, result 72 hours later, pretty strong positive. Again, another way to make a diagnosis in these cases. And so again, most of our cases, it's either cytology or antigen testing, but in many cases, we're doing it all together. We're getting an aspirate, we're submitting it to our lab, our pathologist to look at, we're submitting urine to the Miravista lab. We're usually doing both of these things to try to make a diagnosis. And so again, I think the big thing is awareness. And I think that if you guys have pets here, you're aware, you know, it's the lack of awareness that I think leads to the biggest delays in treatments. And the way they treat humans is pretty similar to how we treat dogs. We generally are using an azole antifungal. One thing that I think is important to maybe be aware of is that dogs that die from this disease, they usually do so within the first 2 weeks of treatment. Again, nothing is ever 100%. But as these organisms start to die off in response to the antifungals, they stimulate a massive inflammatory response. So it's not uncommon for dogs to get worse before they get better. And so some of the dogs that are really, really sick when we see them, we really worry about those dogs because we know they're probably gonna get sicker before they start to get better. Even with really prolonged treatments, and we do the same thing, we're treating from anywhere from 5 months to 12 months in most of our cases. 20% of dogs relapse. Most of those relapses occur within 4 to 6 months of stopping therapy. But even if they relapse, it doesn't mean they're not going to respond to treatment. They usually still do. But the point I'm making is that this is not a 1-week antibiotic treatment for a run-of-the-mill UTI. This is going to be months and months and months of therapy and a lot of follow-up. Most of us use itraconazole. There was a study published a number of years ago from the University of Wisconsin that said fluconazole is just as good. There were a number of problems with that study, but the Wisconsin grads and the people that go to Wisconsin for care tend to reach for fluconazole first, whereas most of us reach for itraconazole as our first line, and I think there's a lot of reasons to do that. I just realized that Dr. Kauffman's one of the authors on these consensus guidelines, but in humans, itraconazole is clearly preferred over fluconazole, and so we're typically reaching for itraconazole as well for most of our cases. But we do use fluconazole, and the reasons that we use it is because most pets don't have insurance. Itraconazole is more expensive. Fluconazole is less expensive. It's very well tolerated. And so we still use it. We generally avoid ketoconazole. That was commonly used back in the 80s and early 90s. As you can see, 50% efficacy is not very good. And so we typically stay away from that. There's a whole newer generation of azole antifungals that probably have a role, again, beyond the scope of what we're chatting about today. But again, usually itraconazole for most of our cases. The other thing I'll mention about treatment, so this is the dog, the little Frenchie that I showed you earlier, that this dog actually was diagnosed with Blasto, started on treatment, came back in blind. And this is another example of oftentimes the disease gets worse before it gets better. And so this dog came in completely blind. And the owners, rightfully so, they said, is there anything we can do to save vision? The answer to that question is often no, but sometimes. And sometimes what we consider using are steroids. And I only mention this because we are not using steroids in most cases. Steroids suppress the immune system, they block inflammation. And so if you throw a dog with blastomycosis on steroids, odds are, if they're not on any other treatment, the disease is going to disseminate everywhere and they're going to die. But for dogs that are being treated with an azole antifungal, for certain instances, we will consider using steroids to quiet the inflammatory response. And probably the big reason we do that are in the dogs that we're trying to save vision. We're trying to get that retina to lay back down. We're trying to preserve vision. So occasionally we will use steroids. Occasionally we use steroids in dogs that have neurologic disease. Most dogs with neurologic disease don't survive. They usually die, but occasionally we can get them through it. And so I just mentioned this as, again, not a common treatment, but in very specific cases, we'll use short courses to try to blunt the inflammatory response in some of these dogs. And so, again, final thoughts. Every dog is different. So there are dogs that present with more milder signs. There's dogs that present that are basically candidates for ventilator therapy. And so our treatments, the level of hospitalization, it's all tailored to that individual patient. We get about 85% of our dogs through this. So probably 85% of dogs survive Blasto, at least in our hospital setting. But even despite all of our efforts, there are some dogs that do not survive. Often those are the ones that we get to very late in the game, or they have central nervous system involvement. Those are usually the cases that are not inevitably fatal, but in most cases are. So I want to just comment, since the last time we did this a few years ago, we are seeing less cases at MSU. And I can't prove as to why, but I do think there is greater awareness amongst pet owners, among veterinarians, among veterinary students that we're sending out to practice in the state. And so I think it's probably a good thing that we're not seeing as many cases as we used to. I don't think the disease is any less common. It's just as common. I just think less cases are making it to Michigan State because they're being caught earlier by their primary veterinarian. They're being caught up here before they make it downstate. And so I do think, again, making you guys aware, giving you a little bit of information, hopefully will help. So that is what I have. I'm happy to answer any questions. Yes. Either or, we'll do. Both of you.
Kind of scared me to death here because I'm on Drummond Island 5 months of the year. I have 3 English setters. They're never off the leash since I found out about this 25 years ago where we started being. But, am I supposed to stop them from sniffing? I walk them daily, 3 times a day, but they sniff and they go,
So I would say Drummond Island's probably the biggest hotspot. I would think. I don't know what Dr. Groover thinks, but it's probably one of the biggest. But I don't know. And we get that question a lot, and you could probably ask 10 veterinarians and maybe get 10 different answers, because if you're going there 5 months a year and that's not changing, well, you don't want your dog never to live or enjoy and do the things that it does. And so I think there's probably some caution on where they're going to be. But at the same time, I think, honestly, if you maintain awareness, you know about this disease, you will hopefully catch it very early rather than wait 4, 5, or 6 months before you finally seek veterinary care. And so I'm not a big fan of completely avoiding everything in the environment, because I think that's almost impossible to do in some areas. But I think if you're aware of it and you're thinking about it, you make your veterinarian aware of it. If they're not, odds are you're going to be able to treat it successfully if you catch it early.
Should they be preventative tested? Sorry.
Oh, so a question, preventive testing. There's a lot of controversy with that. Some people do recommend testing 1 to 2 months after getting back downstate. I think it's valid. I don't know. I think Dr. Groover can probably comment more on that, because we don't see that population. We see the dogs that already have it. We see the dogs that are sick. But I would imagine there are likely some dogs that are caught very early, but it's such a long and unpredictable incubation period. You could have a negative and the dogs still pop up positive a few weeks later, and so it's hard. Do you test right when you get home? Do you wait a few weeks? I think there's value in it. I just don't think we know all of the answers. Yep. Now, if you were to do it every 3 to 4 weeks, great, but then you're spending, $250 to $300 every 3 to 4 weeks, and I think that's exactly, for all 3 dogs. So that'd be a very, very expensive screening. But I think there are a number of vets that do recommend testing when you get back downstate. I don't know if that's the right thing or not. I really don't know.
Okay.
Yeah.
Like she did with the animals, you're trying to watch them and that the dogs never went outside, and we're like, where did these dogs get it? The people were avid gardeners and flower. They'd put their shoes right here by the door. The dogs would come in, lay on them, or lick the shoes and all. And We have had more than one case of that, and that's the only thing we could determine was that they were getting it from the soil on the shoes.
And we sometimes,
Or soil. One dog that actually got it from the new house that the dog that had untreated cedar put around the door frames, and the dog obsessively ate the cedar.
weird cases too, where we diagnosed a cat a couple years ago that was an indoor-only cat with Blasto. So clearly, it came into the environment. I think the paper mill outbreak's a great example where they had people that weren't even working on the assembly line that developed it too. And so clearly, there probably is, I think probably not like some diseases, but there probably are, fomites and other things that, act as, conduits for disease as well. And I think it certainly could be tracked. But you're right, there are cases where, you think you're eliminating every risk factor, and it's probably impossible to do in many situations.
Okay, we'll take one more now, then we'll take a short break, and then come back and finish up about 10 minutes later than we planned. No, that's great.
And my question might be more directed to Dr. Groover, I'm not quite sure, but it was kind of along the same lines as her. I have had my dogs up here for years. I live on Hessel Point Road, and Hessel Point Road was a hot spot for it for a long time. I stopped walking my dogs there. I let my dog go to the lake and come back into the house, and I don't take him anywhere else. But he goes on boat rides, and he goes on car rides. So I don't know if it's in the air floating around like she was talking about, it gets carried around through the wind. I don't know.
Probably not far, and I think that's probably very low risk, those types of, environmental scenarios, but I don't know if they have a comment. I mean, we take our dogs out on the boat all the time. We're out there, and I don't think you're going to find it in the middle of the lake. Again, it's going to be more on the shore, those damp areas, decaying vegetation. I think like cedar bogs are a classic one. But I think, if you have...
Like walking a dog on the paved road, do you think that's good or not?
I would assume very low risk, but nothing is ever zero.
Right.
Yeah.
We had a dog on Hessel Point, one of the first ones that we treated for Blasto. Same scenario, but the dog came down with Blasto, and we traced it back to the stove down in the basement, and the wood that was stacked there was the cedar wood that he was cutting out of his yard and everything. And this same person, at the same time, we had a dog that lived in an apartment that had never been outside or any.
We didn't have, it was in Canada.
Canada, but
The Canadian vets had an upstairs apartment dog that had never been outside. They figured they was chewed up the Christmas tree.
and that's where he got that. So you can know.
And that's where he got it. That was the only scenario they could come with.
That's kind of why I take the approach of I don't think you can avoid every risk factor, and I think the better thing is if you're at least aware of it and your dog does develop symptomology, you can get tested, you can get treatment early, you can have a favorable outcome. The dogs that we see that do die from this disease, they usually have very, very advanced disease. They've usually been sick for quite some time, and MSU was their third or fourth stop. They've been to vet after vet and been treated for, it didn't respond to this antibiotic, we're gonna switch to this antibiotic. And when we see these cases, there's the ones that don't make it are usually the ones that it's just, again, very, very protracted sort of end-stage disease.
One more question. I've got a mic, so I have one more question.
Sure.
You showed a map of the UP. Everything is high risk, except for the Keweenaw.
Yes.
Do you have any explanation for that?
I have none.
As it might pertain to the mining up there, there's a lot of copper mining, and fungi don't
like
well.
copper, yeah, it's static. I don't know, I didn't even think of it from that perspective, but there's two vets up there that I spoke to, and I really asked them, I'm like, are you guys just not testing for it, or are you truly not seeing it? And they said, we do test for it, we do not see it. So I don't know the reasons, I'm not sure. It seems to be, at least the two vets that were there seem pretty confident they are not diagnosing it. But I don't know, that's an interesting theory.
Okay.
The only thing I could say on the Keweenaw is it's more highland. We don't see,
Yeah.
we don't see it from Drummond and never seen it from the limestone ridge where they mine limestone. It's always on the lowlands. So I've just done a verbal check on, well, where do you live?
Yeah.
And my memory of the Keweenaw is a ridge down the middle. Why we don't have it around the edges, I don't know. Maybe because that's not very populated in that.
Yeah.
That's a low population area.
Okay, fair enough. Okay, let's take a 10-minute break and come back, and thank you, Dr. Miller.
Thank you.
Dr. Miller couldn't be here, but she put together a video of her clinic up there that used to be Pickford Veterinary Clinic, Hospital. So when you're ready.
Hi everyone, welcome to the Blasto seminar. My name is Dr. Taylor Miller and I have made a short presentation for you today. I'm just going to go ahead and share my screen. So what I'd like to focus on in my presentation today is clinical presentations we may see with a blastomycosis case in the clinic. To get started, I just would like to introduce myself. My name is Dr. Taylor Miller. I am the owner and practicing veterinarian at Pickford Veterinary Services, located in Pickford, Michigan. It was previously known as Pickford Veterinary Hospital and was owned by Dr. Clinton Gruver and Barb Gruver. My schooling background, I did my undergraduate studies at Lake Superior State University up in Sault Ste. Marie. And I recently graduated from Michigan State University College of Veterinary Medicine in 2023. I am a lifelong resident of Pickford, Michigan. I grew up there, went to high school there, came back to practice here, but I am now living in Cedarville with my fiance. And then I thought you guys might enjoy our pets here. We have 4 dogs, 1 cat, 20 sheep, and 2 donkeys. So here are some pictures for you guys to enjoy. Over here, we have a picture of Patrick and I, and then you can see 3 of our dogs. We have Smokey, she's Australian Shepherd, Gus, who's our Corgi, Coda is our Husky mix, and then we have recently acquired this little golden girl here. Her name is Val. She has some heart problems, and so we've taken on her care and we're taking care of her. And then there's a few of the sheep, a couple of the donkeys, and then our 1 cat, Nash. So the goals of this presentation today are going to be to discuss clinical signs and symptoms, and I'm going to do that via a case study that I had recently in the clinic. And then I would like to go over a protocol for the testing and how we like to do our testing at Pickford Veterinary Services, and any recommendations I may have in regards to testing. So to get started with our case, we're going to talk about Theo. He is a 2-year-old male castrated beagle. He first presented to the clinic in early fall for a lesion on one of his forearms. Owner said it had been there for a few days. Dog was licking at it, kind of bothering him, and they just wanted to get it checked out. His physical exam was relatively unremarkable. Everything was within normal limits. His temperature was normal. His heart sounded great. Lungs were nice and clear. Happy, healthy little beagle. He just had a small circular red cutaneous lesion. It wasn't draining at that point. It seemed particularly superficial, so just kind of right on the surface of his skin. You could clearly see that he was bothering at it. And owner and I discussed some history, and we suspected that Theo may have injured himself in the woods or running along the river that they have near their house. So I recommended we start antibiotic therapy and then go ahead and recheck him if it still hadn't gotten any better. And then also to put the cone of shame on him so that he couldn't lick at the lesion. So 2 weeks later, the owner called noting that Theo had not improved, wasn't feeling very well. So we had them make an appointment to bring him back in. The area or the sore that we looked at previously looked better, but it still wasn't completely healed. And then he presented with some other clinical signs. So he was pretty lethargic. He didn't really want to eat. He had another red raised lesion present around the dew claw of his left front paw. It was also kind of draining. The owner noted he had been squinting, his right eye seemed really painful. The dog really didn't want them to pet him or interact with him. And then he also had a strange swelling over his rib cage, kind of under his skin. So on physical exam, it was noted that Theo had a pretty elevated body temperature. He was running a fever of around 104. A normal temperature for a dog is 101.5 to 102.5. So Theo was feeling pretty punky. OD, that just means oculus dexter or right eye. It appeared pretty painful to Theo. He did not want me to come near the eye. He was squinting. He was shying away from us. He did try to bite as well, just because it was very painful for him. So I went ahead and I numbed up the eye with a few drops, proparacaine drops that I have in the clinic. And then we went ahead and took his ocular pressure, which was quite elevated. Now, normal pressure you can see there I have is 10 to 25 millimeters of mercury. I have an old tenometer from Dr. Groover. It works, so we still use it, but it only measured up to about 20 when you look at the scale. And when I kept touching Theo's eye, it was going all the way to the end. So it was indicating to me it was probably well over 20, which is very high, and it is very painful. And then we call increased pressure in the eye glaucoma. And then looking at the lesion on his left front paw, the dew claw was very red, swollen. The nail appeared infected. It was oozing this really thick green or thick gelatinous drainage, and it was very much bothering him. And then over his right rib cage, he had a small swelling. It was soft, but it felt quite warm, was also very uncomfortable for him. So then I did a fine needle aspirate. So I stuck a little needle in there to see if I could get anything out. And out was a very thick, purulent discharge, or purulent like fluid, indicating it was some sort of abscess that he had gotten on his rib cage. So with all of these clinical signs presenting, we dove a little deeper into Theo's history with the owner. I said, did he do anything different? Did he get into a fight with any other dogs? Any significant changes that way? Owner noted the dog had been himself doing normal things around the house the past 2 weeks, didn't go anywhere new, didn't meet any new dogs. He did state that they did live along the Monuscon River in Pickford, and that Theo really liked to play along the riverbed. He liked to dig, he liked to swim, he was always down there. So the next step in the case, I had to think of some differentials for why Theo may be feeling ill. Of course, because we've seen a lot of these weird symptoms before, I automatically did think of blastomycosis being, high on the list. It causes a fever, it can cause sores, but sometimes not all at once. So it was a little strange. And then we also have to think about something like juvenile glaucoma. Theo is a young beagle, but they are genetically predisposed to developing glaucoma in their eyes. So we had to keep that in mind. And then I thought, well, maybe it's just some weirdo bacterial infection that, we maybe missed with the last antibiotic that we had used. So due to his clinical signs that I had noticed in the clinic, I recommended testing the dog or sending the urine away to test for blastomycosis, and to begin antifungal therapy prophylactically, I guess, in case it was that, to start getting treatment on board. So I went ahead and started Theo on itraconazole, which is an antifungal that I prefer to use in blastomycosis cases. He was started on that. I also went ahead and started a separate antifungal for his eye specifically. Voriconazole seems to cross better through in the eye and to treat that fungus if it's in the eye. I also did treat him with a neomycin polydexamethasone drop for pain relief in that eye, just because he was so painful. I also started him on a nonsteroidal anti-inflammatory to help bring his fever down. And then we also continued an antibiotic therapy as well. Off chance we had both things going on, whether it was bacterial infection or it was something like a fungal infection like Blasto. So I recommended we send his urine away, as I stated, to Mira Vista. When we send a urine off, we only need about 1 ml of urine. It doesn't have to be sterile. It could be a free catch. So we just need a small amount. And as you can see here, Mr. Theo did come back positive. So his level was 7.8 nanograms per mil. Not the highest that I've seen, nor has Dr. Gruber seen, but, you know, a good level that was probably making him feel quite ill. And then this is just a typical report that we would get back from Mira Vista. This is what it looks like when we test your dogs and when we see if they're positive or negative. So the outcome of Mr. Theo's case, he did maintain a fever for several days. He was pretty ill. He didn't want to eat. He didn't do much. Finally, after 4 or 5 days, the fever did break and he was starting to feel much better. He was eating again for us. He was interacting with his family, the other dogs in his household. We did continue him on the antifungal therapy in his eye, and after doing that for about 3 to 4 weeks, his ocular pressure did return to normal, which is great because sometimes when we have blasto in the eye, it can severely damage their eye, and they are at risk of losing their eye. So we were really lucky, and we were able to save Mr. Theo's eye. All of his cutaneous lesions that he had been experiencing did regress, and his rib cage abscess also went ahead and healed up as well. Because Theo was doing so well, we did keep him on the antifungal therapy for 6 months. What we do is we run a bioassay, so we draw some blood at around 3 weeks of him being on the antifungal therapy. We do this to make sure that the itraconazole isn't harming any of his other internal organs, specifically his liver. His bioassays all returned normal for us, so we continued his therapy for 6 months. At his 5-month mark of being on itraconazole once a day, we retested him, and he had his first negative test, which was great. And then in 30 days, we retested him again, and he was negative. So we were able to say that Theo was in remission or he was in the clear, and we had treated his blastomycosis successfully, which was great. And he is a very happy beagle now. I saw him recently just for his, regular visit, and he's doing fantastic, which is great. So I just want to reiterate and talk about the clinical signs. So Theo never presented with a cough to the clinic. He always had normal sounding bronchosvesicular sounds. Now, mind you, I didn't take any radiographs of him to check his lungs, but I didn't feel that they were necessary, as he always sounded great. But I do feel like sometimes we automatically think that blasto patients are going to have a cough when they don't, right? So Theo definitely had clinical signs that could have been misdiagnosed had we not known about blasto. One being his increased ocular pressure. We could have just thought that he was suffering from glaucoma and started to treat him that way. His cutaneous lesions, we could have just continued to go down. It's a bacterial infection route, and they typically don't ever heal with treatment. His abscess, we could have blamed that on running into something again, or he got bit by something. And that also could have been misdiagnosed. The only common thing that he did exhibit was a lethargy. He was lethargic and he had a fever. But just to reiterate, not every blasto case presents with a cough. We can have eye issues. We can have a lameness, swollen joints, the fever. We can have the cutaneous lesions, abscesses. It can sometimes present in the bone, and it can present like an osteosarcoma or bone cancer. It can cause seizures if it seats in the brain. So it's very important that we recognize that Blasto has a very wide range of clinical signs and symptoms that we need to look out for. And it is important, if you are in our area and you're noticing these weird things in your pet, that you voice those concerns, and that Blasto doesn't get overlooked in regards to your pet's health. So here at Pickford Veterinary Services, we're very happy to help you test your pet before you leave the area for the fall or the winter. We do request that we want to see your pet in person. We want to meet that dog. We want to meet you. We want to weigh the dog. We want to listen to them, take their temperature, make sure everything's looking okay. We do not want you just dropping off urine if we've never met your pet. And that does mean if Dr. Groover's seen your pet, it doesn't mean that I've seen your pet. So I really prefer if I could meet them myself before we test them for Blasto. We do encourage the owners to make an appointment with our office about 2 weeks before they're planning to leave the area. And if you're wanting to be tested for Blasto, you do need to bring a urine sample with you that day. By making the appointment 2 weeks before you leave, it allows us a wide time frame that we can get those test results back, and we have time to discuss our treatment plans and options for treatment with you, or if you're going to choose to treat through our office, or we can help facilitate treatment through your referring veterinarian or your veterinarian at home. And then I just went ahead and put down there our clinic hours for you, just so you know. So we are open Monday through Thursday, 8 to 4, and Friday from 8 to 12. We are closed daily from 12 to 1 for lunch. But we are more than happy to help you. We just request that we get to meet you and meet your dog first, so that we can, or cat first, so that we can make sure we're doing all the correct things for them. And then say you get home, you didn't test before you left the area, or you did test and your dog tested negative. We do know that Blasto can lie dormant for several months in patients. So meaning they can be exposed in the summer, and then there's a stall in presentation until later in the fall or early winter. And so it's very important, if you are in an area where you're maybe concerned that they don't know what Blasto is, or just advocating that you want your dog tested for that, or your cat. We personally use Mira Vista Diagnostics. They're very, very helpful if you call them, if you have any questions. They're also very helpful if your referring veterinarian is, so say you went back home to Florida and they don't, haven't heard of Blasto or don't know what they're doing, or if they just have some questions, they can always call Mira Vista and they will answer questions. They will help with treatment. They're very great there. Really enjoy working with them. And then the biggest thing that I just want to put out there is you need to be an advocate for your pet and yourself. So knowing that you are in an area that's highly endemic when you're here for the summer. And so if your pet does go home and get sick, you need to make sure that you're advocating for them and saying, I want them to be tested for this. I want to rule it out, because it is something that could be, life-threatening to your pet. The other thing too is you can get it yourself. And so it's very important that you also advocate for yourself. If you're sick or in the hospital and there's weird respiratory or cutaneous things going on, you definitely need to advocate for yourself, and potentially be tested for Blasto. So I just want to say thank you for being able to come to the seminar today. I have seen the lineup. It looks like there's some great talks ahead for you guys. I just want to say thank you to everyone who has put the seminar on. Thank you to Dr. Groover, Dr. Langlois, and Dr. Kauffman for coming up, and also Robert Smith as well for presenting, and then everyone at the Hessel Schoolhouse for putting things on for us. So thank you very much again. And then if you need to see us at Pickford Veterinary Services, feel free to give us a call and we can get you an appointment to help your dog or cat be seen for Blasto. And then there's just my sources there. So hope you enjoy the rest of the afternoon. It was nice to meet you virtually. Hopefully I can meet you in person.
She cannot hear that. If you have questions for Dr. Miller, possibly Dr. Groover can answer them after the fact, or if you have specific questions for her, I'll write them down and get in contact with her next week, and we'll make sure that you do contact her in person. She's done a nice job up there. Okay, we're there. I'm going to probably go down another rabbit trail here, like Theo, and something that I just learned a little bit about, and then I learned more, and then it became an obsession. But in talking with Dr. Full disclosure, we are cat people. But in talking about Blasto with Dr. Groover, I was intrigued that his clinic and other practicing veterinarians will have a Blasto case. They use the protocols that have been proven over the years, and they have different outcomes. Why is that? So that's what got me beating the bushes to try to get some sort of answer to it. Because when the case is over, if the dog lives and he's healthy, that's great. But if it's anything less than that, the vet says, why? What did I miss? The animal owner says, they tried the best they could, but it wasn't in the cards for my animal. So that's what led me to put together these few slides here. And let's say you have multiple animals. They're about the same species, age, and health. They've got the positive antigen test, and you get different outcomes. Now, again, using the same protocols, we're looking at a full recovery, a recovery, then a relapse with eventual recovery, a recovery, and the dog remains, he's healthy, he's running around, he's having a good time, he acts normal, but when they do the Miravista antigen test, it comes up positive. And this comes up time after time, and, well, I won't go into that. Or no recovery. So I know that bothers practicing vets, and it bothered me as well, just because I like to have an answer. There was a timely diagnosis, or maybe the dog was really having these symptoms and the owner didn't pay attention to it for too long a time. There are underlying issues. Maybe this animal has diabetes. That's going to affect what's happening here. And then also, was a drug choice and the timing proper for all the other conditions? But looking at the overall picture, what did I miss? That something came out different from what I expected as a total cure. We're going to look at DNA. Now, this isn't something that you're going to be equipped for in your average clinic, but it's a question to ask. We're going to dip our toes in the DNA pool, the shallow end, for just 1 minute, and to get a feel for where we are here. We have the chromosome proper. The DNA is in the chromosome, and then portions of the DNA. We have genes, and the genes, we all know, they will confer stature of a person. They'll confer your eye color, your hair color. And in the case of Blasto, it's been found that there are packets of genes, clusters of genes, that code for blastomycosis, particularly in dermatitis. And these clusters or packets of genes are called haplotypes. Marshfield Clinic over in central Wisconsin, it's a Blasto endemic area, have been publishing on Blasto for the past 15 years, the genetics of Blasto. This past year, they reported that Gilchristii affects mostly young humans, and it's strictly restricted to pulmonary symptoms, and typically it lasts a short time, and there may be hospitalizations, but that's it. Now, Dr. Kauffman, do you agree or disagree with this comment from Cleveland Clinic? Because I have no clue.
The problem is most times it's not identified as Gilchristii or dermatitis, and so it's called dermatitis, but in fact the labs can't differentiate them unless they do genomic testing.
Yeah, okay.
So I don't know that I can answer it.
Okay, well, I'm on thin ice. I'm going to keep skating now. Whereas dermatitis, it will infect humans and dogs, and it's more likely to cause a disease in a dog than the Gilchristii, but it's also more likely to spread throughout the animal's body. Two other species, Helicus and Percussus, there's no published information on them causing infections. So we'll go back to, this was a paper from them in 2024. We go back a few years. In 2010, Dr. Meese, she was on the CDC committee that worked at Escanaba on the outbreak over there. She sequenced 106 samples, both clinical and environmental, and she found 4 of these haplotypes, these clusters of genes, in that set. In 2013, Dr. Anderson used a more sensitive method to identify and sort out the genes and the haplotypes. And out of 300 samples, she got roughly a third of those were haplotypes, different haplotypes, 59 from vets, 130 from humans, and 3 were virulent both for humans and for veterinary cases. So key here is 59 from vet sources. This is starting to key in on the issue. A lot of diversity here in the genetic makeup of these strains that are affecting your animals. So with that, how do we then sort out the outcomes whenever the animal is treated? This is my wrap-up slide, basically. Primary species for vet cases, the haplotypes and the diversity just has to throw. If I were a practicing vet, I'd be very upset at the end of the treatment, because you did everything you could. You took the physiology of the animal into consideration, any underlying circumstances. Still, you come out with an outcome that you did not anticipate. So if I'm a practicing vet, it helps me to know that I did everything I could, knowing the state of the art, yet I couldn't get the animal back to perfect condition. Is this something that vets can use in the short term? No. They've been working on this for several years, as I said, at the Marshfield Clinic, and perhaps in a few years you'll have access to something similar to Mira Vista that you can send out a sample, have it returned quickly, because these are not time-consuming tests, but the average vet clinic can't rationalize a $500,000 instrument in his or her lab to quickly analyze this. And with that, I will leave you with a quote from Father of Microbiology. In the end, it's a microbe's call. So, with this, I'm going to turn the mic over to, if you have any questions about that, shoot me a quick question. Otherwise, we'll give the mic to Dr. Groover, and you can ask him. He has a few things he wants. You can say a few things, or you can listen to questions. Did you have anything? Did you have anything you wanted to say first?
Yeah, maybe I should.
Let me see. I'll grab this on. Yeah. Is the shirt, is the pocket okay or higher?
Well, I can take questions first if that would make it easier on people that want to bug out from my boring presentation.
All right. Who has a question first here?
I guess I just have a general question about, you mentioned the repeating infections in animals. Does the same occur in humans? So that's not really a question for Dr. Gruber.
Well, yes, I mean, humans can relapse, which is why we usually treat for 6 to 12 months. In the old days, when I was a fellow, we had only amphotericin B, and it's pretty toxic. So we would treat patients for maybe 2 weeks, 4 weeks, if we could get away with it. Had to stop because there were no azoles, and we then frequently saw relapses. People coming back with more skin lesions, that sort of thing. Since the azoles have come into practice in the 90s, we rarely see these kind of relapses anymore. Because we treat for a long period and we can safely treat.
I have to comment because I'm deaf or no post.
5, 4, 3, you're on.
Okay. Well, just to show you that preventive medicine doesn't always work, my blood sugar was falling, so I took a dextrose tablet to cure it and got the Kauffman almost to interrupt everything. So anyway, basically I'm supposed to try summarizing and give you takeaways. Any human or dog that is living or visiting this area is potentially exposed to Blasto. There's an increased risk when you, or the dog, or especially the dog, is in a wet area, a high organic soil area, which means a swamp or a woodland area. Acid soil, the organism seems to prefer acid soil, and they can't tell whether it prefers it or whether it can survive acid better than other organisms, but it appears to show up more in acid soil. Any kind of soil disturbance or the destruction of old buildings would seem to increase the risk. Basically, old buildings get wet, they're organic, and they get mold or potentially Blasto. The second thing that I would like to try to get across is that you need to be your own advocate. It is important, especially when you're not in this area. Even sometimes in this area, you have to jog people's memory, whether it's a physician or a veterinarian, that I possibly have been exposed or my dog has been exposed to to Blasto. I recommend that if you're here on vacation for a long period of time, not for a week, but for a month or so, or you have a summer home here, I would personally test before I left or when I got home, and then again 4 to 6 weeks after you return home. And after the last seminar, we had, I don't know, 50 or 60 people come and have the urine test run. And I can't remember how many positives we had, but I think it was up to 30% of them were positive. And a good 80 to 90% of the positives were not symptomatic. So there's a problem that a lot of the vets, say you're home and you run the test, a lot of the vets won't treat a positive dog if they're not symptomatic or if the symptoms are very mild. And I have a real problem with that because after that same situation, we had a dog that was tested in August, I believe, late August, it was negative. I think it was tested again in September and it was negative, and it was tested again in October and it was negative, and then it almost died in December from Blasto. So we know that there are different breeds, if you will, of the organism, and each one of them may act different. The organism can lay dormant and then flare up later. We don't know how long on any of those things. So you have to continue to be vigilant even into December, January, February. If the dog becomes sick at that time, you still have to consider that it could be Blasto. A lot of vets, as Dr. Langlois pointed out, it's not on their radar. So you got to drill it into their head. If they won't listen to you, if they won't run a test, if the symptoms that you've heard about today or any other thing that didn't respond to treatment is showing up, that they test for Blasto. If they won't, find another vet. Because it is, we've lost a lot of dogs over the years, and at least that I can remember 3 people but just because somebody wouldn't test. And it's, you know, if it was a life-threatening test, I wouldn't recommend it. And of course, I don't recommend anything for humans. I really don't think that having a preemptive test in this case would be what I would think appropriate, but that's out of my department. But for dogs, they're so much more susceptible to it. There's so many more cases of it. And we did catch, and the big thing is with those 20 or 30 positives we had on the preemptive testing, we don't know how many of them would have blown up in December. We know that one of them that was negative blew up in December, but how many of those others? Because we don't have any way at this point of testing for which species or which genetic type of the organism we're dealing with. And even if we did have a way of finding that out, we wouldn't know what the information meant because nobody has categorized different species or genetic breeds, if you will, on certain diseases. So I just told you what I wrote next, so I got to find where I am in my notes. The good news is that the tests and the treatments are all the same. All of the discovered haplotypes and species all respond to the same test or activate the same test, and they all respond to the same treatments. If you're worried about Blasto at a later date in the situation, say you've been home a while, it was negative, if a symptom shows up that concerns you, find somebody that will run a test of some kind to find out what's going on. A lot of vets in a lot of areas that we've seen want to run a serum test for the antibodies. I don't think even when there was dogs that were deathly ill from Blasto have I ever seen that serum test show positive. Doesn't mean that it won't or can't. It just means that it's not accurate. So even though that may be what they want to do, make sure they do something else, like a biopsy if there's a lesion, or the urine or serum test, a Miravista. And if you don't think you're getting what you want, try to get the vet to either call Dr. Langlois or the vets at Miravista, because all of them will talk to another vet. And then Dr. Kauffman has said she would talk to physicians, I think. So if you yourself are having problems getting what you want, try to get her to intervene. Guess I'm lost again. You know, after the last seminar, Barb spent most mornings talking to people about Blasto. So it was helpful at that point. We thought we educated a lot of people, and we thought we helped a lot of people. She also made up packets of material for the vets at home so they would have some protocol to follow. We don't know if it was the right protocol, but it was the one that we used, and it had worked for us. So that's not going to be available now. We're retired. We don't have access to the mechanical stuff that makes and prints stuff. Plus, we don't know what anybody else is going to do, so we don't want to advocate for what can be done when we don't know what can be done. Always be aware that it can be a problem, even into the winter. It can show up anytime. We've had it in every month of the year. According to the microbiologist here, the organism sporulates from August to October. So the numbers of spores in the environment vary from time to time. So what we've in the past seen is that December was the most, in the month that we saw the most cases. Now, with the preemptive testing, we're seeing the most cases in the early fall. And I do think that a lot depends on the seasonal weather that we've had, whether we have a bad year or a good year, good being not so many cases. And the other thing that I think is important, and Dr. Langlois alluded to that, is that the treatment should be based on the symptoms that you see, not worrying so much about what form or breed of Blasto it is. The treatment should vary anywhere from the IV amphotericin all the way to pills at home. Personally, other than 30 years ago, I gave up on the amphotericin B because I didn't think I was competent to do that. So if there's something that's really bad that needs that level of treatment, I would take it to MSU or some other specialty clinic. Again, I can't stress it enough. Make sure whoever you're dealing with will listen to you and do the testing. And if they don't know what they're doing, get them to call somebody that does, or ship it out to another hospital or a vet. I don't think I got anything else to say.
Good enough.
I'm ready for questions if there are any.
Joe?
You'll have to reread the question because I'll never hear it.
Well, I don't write too well, so we're in trouble.
What's that?
Well, I don't write too well, so we're in trouble. Okay, Joe?
I don't have a question, but I have a comment. I would like to publicly thank Dr. Gruber for the that he has done in this area on blastomycosis, and for the very wonderful work that Barbara has done as a team. And I'd like to thank you and acknowledge the great work that you've done as a rural veterinary practice.
Thank you.
I know I grew up in Hessel here, and I had blastomycosis. Done a study with Janice at Pharmacy. It saved my life. I was lucky. There's only 10 in the world that got on it. I was 46 years old. I had 3 kids. In February 17th, 1987, I consented for the study with Janice and Pharmacy. I signed my consent decree, and I was 46 years old, and that was about 29 years ago. I'm 84, and was very happy to participate in that study. And
Yeah, thanks. That's good because you're a success, bud. You're a success. Jan, did you want to say anything?
I'll just comment that we were doing that study at the University of Michigan with Dr. Geary, who you saw in Petoskey at the Burns Clinic. In those days, it was pretty laissez-faire. I had itraconazole in my desk drawer that Jansen had sent to me, and I would just send it up to Gunnar, and he'd send me back your pictures and the data. We don't do that anymore. Things are much more highly regulated, probably rightfully so, but we were so glad you participated. It was wonderful, bud. Thank you.
Oh, boy. We're in deep yogurt. Well, thanks to both of you. We'll go on to another, any other questions over here? Yeah.
Might I just say that all of you got this little brochure. It probably needs some updating on it, and for the Community Foundation, we have the Blastomycosis Fund, and Rick Shapiro is very instrumental in making sure we sent this to every single vet in the state of Michigan about 2 years ago. And only one person called back to say, please take me off your mailing list. But I like what Dr. Groover was saying about the summer visitors should take information back to their home vets that might be outside of Michigan or not know about this. But I think it's time for us to probably update this a little bit, and I would love the experts to give any feedback to the Community Foundation, because we have a fund for that purpose. And the Pickford Pickford Vet has been really great about, we keep you guys updated on this. But it can be very helpful to get it out beyond the borders of Michigan.
I just wanted to say something about this. And Dr. Kauffman, you might know more about this, but at the last seminar, there were a couple of local people who had retired and bought their old family cabin. And they were going to come to the seminar, but the weather was beautiful like this. So they stayed there, lifted the cabin, and worked on digging under it and trenching it and everything like that, instead of coming. But they had stopped by and picked this up. A few days later, he got sick. And they took him to a hospital with this in her hand and said, I think he has blastomycosis. I want you to test. They said he had pneumonia, put him on some medicine, and sent him home. 9 days later, he was worse. Went back, they transferred him, then they transferred him again. Then he got to infectious disease down at your way, and they did a Blasto test, and it came back positive the day of his funeral. Now, this is not meaning, don't come up here, don't be scared to do that. But when they all say advocate, he had this in his hands. So.
Okay, thanks. Any more comments? Okay, we thank you for coming, and we hope that the results of this seminar are as good as the first seminar, in that we have a lot more awareness and a lot more consideration of Blasto whenever the vets or the physicians are diagnosing. Thanks again.